Welcome to another episode of Uncovering Bailey in Love with Snazzy Surgeon.
Yeah, right.
Today, we're going to be talking about something that's, bread and butter for us.
Yeah.
It's something that we deal with literally every single day, and that's breast cancer staging.
Absolutely.
We're going to be talking about the 8th edition of the UIC AJCC TNM system.
Right.
This is really what drives all of our treatment decisions, right?
Yeah, you got it.
Yeah.
This staging system is so important because it really impacts like every decision we make as surgeons and obviously what we tell our patients about their prognosis.
Yeah.
So having a really good understanding of like the T, the N, and the M classifications is just absolutely crucial for any surgeon who's out there treating breast cancer.
Okay, so let's get started. Let's start with T,
Okay.
the primary tumor.
All right.
So this is really about how extensive the tumor is locally.
Right.
We're mainly talking about the size.
Yeah.
So we're going to start with T. TX is where the primary tumor cannot be assessed.
Right.
All right, so then we go to T0,
Yeah.
which is no evidence of a primary tumor.
Okay.
And then TIS.
Right.
TIS is where we're talking about DCIS
Yeah.
and Paget's disease of the nipple,
Right.
with a big caveat.
Yeah, that's right. So for T's with Paget's, there should be no underlying invasive carcinoma or DCIS
Okay.
in the breast parenchyma.
Right.
So if there is, then we stage it based on the parenchymal disease.
Okay.
But the presence of Paget's itself is still noted.
Got it.
Okay.
So now moving on to T1.
Yeah.
So this is really where we're talking about invasive disease.
Right.
And T1 means that a tumor is 20 millimeters or less
That's right.
in its greatest dimension.
Yeah.
And we even have gradations within T1.
Right. You know what's amazing? Like even within this like pretty small size range,
Yeah.
there's still like important clinical implications.
Right.
Yeah.
So tell me about those gradations.
So we've got T1 IMI, which stands for microinvasive.
Yeah.
And this is where the tumor is a millimeter or smaller.
Right.
We're talking like it's just a tiny little cluster of cells.
Yeah.
And then we have T1A,
Okay.
which is going to range from over 1 millimeter up to 5 millimeters.
Okay.
Now, this is where we have that really important rounding rule.
Right.
You know, a tumor that measures greater than 1 mil but less than 2 millimeters actually gets rounded up to 2 millimeters.
Oh, yeah. I remember that.
Yeah. And it seems like a small detail, but trust me,
Yeah.
these tiny differences can actually sometimes impact, what we decide to do next.
Yeah, for sure.
Yeah.
Especially when you're thinking about adjuvant therapies and things like that.
Exactly.
Okay, so that millimeter level precision is key.
Yes.
All right, so then after T1A, we've got T1B.
Right. So T1B, that's for tumors that are bigger than 5 millimeters but not larger than 10 millimeters.
Okay,
Okay. And then we have T1C
got it.
for tumors that are bigger than 10 but still under that 20 millimeter upper limit for T1.
Yeah.
It's this, careful, stratification,
Yeah,
even within this small tumor size,
yeah,
that helps us figure out what to do.
yeah.
Especially when we were thinking about, adjuvant therapies.
Right. So once we hit that 20 millimeter mark?
Yeah, once we go over 20 millimeters, we're moving into T2 territory,
Okay,
which is for tumors greater than 20 millimeters, but not bigger than 50.
okay.
All right, and then T3.
Yeah.
T3 is pretty straightforward, and any tumor that's bigger than 50 millimeters.
So at this stage, you can actually feel a pretty big difference clinically.
Yeah,
huh?
you're right. Clinically, you can really tell the difference.
Okay.
So now we get to T4.
Yeah.
This is where things get a little more complicated.
You're right.
So T4 describes a tumor of any size that has extended directly into either the chest wall or the skin, or sometimes both.
Yeah.
And this is where our surgical approach, often has to become a bit more aggressive.
Right. And we have some important subcategories within T4.
Oh, yeah, absolutely.
So
Yeah.
T4A, that's when the tumor has extended to the chest wall.
Yeah.
And the definition here is very specific.
Yeah, it's important to be really precise here. So we're talking about the ribs, the intercostal muscles, and the serratus anterior muscle.
Yeah.
And here's a key point.
Right.
Just involving the pectoralis major muscle that doesn't count as chest wall involvement.
That's a good point.
Yeah, that's something that often comes up, in our multidisciplinary tumor board discussions.
For sure.
Yeah.
Okay, so then we have T4B.
So with T4B, we're talking about ulceration of the skin,
Okay.
the presence of what we call satellite skin nodules.
Right.
These are separate from the primary tumor.
Yeah.
And peau d'orange.
Okay.
But remember, peau d'orange doesn't automatically mean that the patient has inflammatory breast cancer.
Right.
We really have to look at the extent of the peau d'orange and other clinical findings to make that distinction.
Right.
Yeah.
Okay, so T4C.
Right. So T4C is when we see both T4A and T4B findings together.
Okay, makes sense.
Makes sense, right?
Okay.
Okay, and then we have T4D.
Yeah.
Now, this one is inflammatory carcinoma,
Right.
and this one has its own unique clinical presentation.
Yeah.
So we're looking for peau d'orange and redness that involves more than 1/3 of the breast surface.
Okay.
And there may or may not be a palpable mass.
Right.
This is a whole different ballgame in terms of how we manage it.
Yeah, absolutely.
Yeah.
Okay, so we've talked about the primary tumor. Now let's move on to CNN.
All right, CNN, that's all about the regional lymph nodes. So we're trying to figure out, has the cancer spread to the lymph nodes?
Right.
And this is often like the most important factor in determining prognosis and if we need to give adjuvant therapy.
All right, so how do we assess this?
Okay, so we start with CNX.
Okay.
This means we can't assess the regional lymph nodes.
Okay.
Maybe because they were removed during a previous surgery or something like that.
Right, right.
But then we see an arrow. That means no regional lymph node metastases were found based on imaging or a clinical exam.
Right, but we know that imaging isn't perfect.
Oh, yeah, for sure.
So that's why we do the sentinel node biopsy.
Right, exactly. Sentinel node biopsy is so important to make sure we're not missing anything.
Okay, so then CN1.
All right, so CN1, that means there are metastases to movable ipsilateral level 1 or 2 axillary lymph nodes.
Okay, so those are like the lower and mid-axillary nodes that we feel during our exam.
Yeah, exactly. The ones we palpate routinely.
Yeah,
And we also have CN1A here,
right.
which means micrometastases.
Yeah.
So these are tiny little metastases.
Okay.
They're bigger than 0.2 millimeters, but not bigger than 2 millimeters.
Got it.
And even these tiny deposits can be important prognostically.
Interesting.
Yeah, it's crazy, right?
Yeah.
All right, so then we move on to CN2.
Okay.
So CN2 tells us that there are metastases in the ipsilateral level 1 or 2 axillary nodes that are either fixed or matted.
Right, so that's that clumping we sometimes feel.
Yeah, exactly.
Yeah.
Or it could mean that there are metastases to the internal mammary nodes, but the axillary nodes are negative.
Okay, so these are kind of different patterns of how the cancer spreads regionally?
Yeah, there are different patterns for sure.
Okay.
So we have CN2A,
All right.
which is specifically for those fixed or matted axillary nodes,
Okay.
which suggests a more significant nodal burden.
Got it.
And then we have CN2B,
Yeah.
which is when the metastasis is only in the internal mammary nodes.
Okay.
And this is often something we pick up on imaging.
Yeah.
And, depending on the findings, this can change how we plan radiotherapy.
Right.
Yeah.
Okay, and finally, in the CN category, we have CN3.
All right, CN3. So this one means that there's more extensive regional nodal involvement,
Right.
and it can involve several different lymph node groups.
Yeah.
And unfortunately, this often means there's a higher risk of recurrence.
Right.
So within CN3, we have a few subcategories.
Okay.
CN3A.
Yeah.
This means there are metastases to the ipsilateral infraclavicular lymph nodes.
Okay.
Or level 3 axillary nodes.
Right, so those are higher up in the axilla towards the collarbone.
Yeah, exactly.
Yeah.
And this can be with or without involvement of the level 1 or 2 nodes.
Okay.
Okay, then we have CN3B,
Got it.
which means metastases to both the ipsilateral internal mammary and axillary nodes.
Okay.
And lastly, CN3C.
Yeah.
This means metastases to the ipsilateral supraclavicular nodes.
Okay.
Again, with or without involvement of the axillary or internal mammary nodes.
Right. So when these higher nodes are involved,
Yeah.
that often means we need a more comprehensive treatment approach, right?
Yeah, you got it. It definitely changes our strategy.
Okay.
Okay.
So that's the N category.
Right.
So let's move on to M.
Okay.
M, distant metastasis.
Right.
So thankfully, M0 means no clinical or radiographic evidence of distant spread.
Right. That's the good news scenario.
Yeah.
And then we have CM0 plus saddle.
Okay.
This is a really interesting category. So this is where there are no obvious signs of distant metastases on clinical exam or imaging.
Okay.
But we find microscopic tumor cells that are smaller than 0.2 millimeters
Okay.
in the blood bone marrow or other non-regional tissues.
So we're talking about like circulating tumor cells.
Exactly like circulating tumor
Yep.
cells.
Okay.
And, we're still learning about what this means clinically.
Yeah.
But it definitely highlights the fact that cancer cells can spread very early on.
Right. Okay, and then CM1.
CM1 is pretty clear-cut.
Mm-hmm.
This means we found distant metastases either on exam or on imaging.
Right.
And this stage, really changes how we approach treatment.
Yeah.
We often have to shift our focus to systemic therapies.
Right.
Okay.
So now we've gone through all of the T's, N's, and M's.
Right, we've got all the pieces.
But it's not enough just to understand them individually.
Right.
We have to put them all together to figure out the overall cancer staging group.
Yeah, exactly. That's how we get the whole picture. So we go from stage 0 all the way to stage 4.
Right. And this is what we use to actually talk to our patients.
Yeah, that's right.
And what guides our treatment decision.
Exactly. It's the roadmap for how we manage the patient.
Right.
So let's go through the stages one by one.
Okay.
All right, so stage 0,
Yeah.
that's TIS N0 M0.
Oh, okay.
So that means DCIS or Paget's without any invasive disease, no lymph node spread, and no distant metastases.
Right.
So pretty localized.
Yeah.
Okay, then we move on to stage 1.
Okay.
So stage 1, that's T1 N0 N0.
Right.
So the tumor is up to 2 centimeters.
Okay.
There's no lymph node involvement and no distant metastases.
So again, relatively localized disease.
Yeah, exactly.
Okay.
All right, so as we go through the stages, the combinations reflect, a greater burden of disease.
Right.
So stage 2A can be T0, T1, or T2.
Okay.
With N1 disease if the T is T0, T1,
Okay.
or N0 if the T is T2, and it's still M0.
So the tumor can be up to 5 centimeters at this point.
Right up to 5 centimeter.
Yeah.
And it's interesting, so sometimes we see that different combinations of local and regional disease can actually fall into the same overall stage.
Yeah, it is interesting how that works out.
Yeah, it is.
Okay, so then 2B.
All right, so stage 2B is either a T2 tumor with N1 disease or a T3 tumor with N0 disease.
Okay.
Still no distant spread.
So for 2B, the tumor would be larger than 5 centimeters.
Yeah, that's right. Larger than 5 centimeters.
Okay.
Right. And then stage 3A gets a bit more complicated.
Yeah, 3A, there are a lot of different combinations.
Yeah, there are. So it includes T1, T2, or T3 with N2 disease if the T is a POT1 or T2,
Okay.
or N1 or N2 if the T is T3.
Okay.
But all of them are still N0.
Right, no distant spread.
Yeah,
But the lymph node involvement here is definitely more significant.
it is.
Yeah.
All right, and then we have stage 3B.
Okay.
This one's a little more straightforward.
Yeah.
It's any T4 tumor with any N category, but still N0.
So basically the tumor has spread locally regardless of what's going on with the lymph nodes?
That's right.
Yeah.
Then we have stage 3C.
Okay.
This is any T with M3 disease and again M0.
Right, so 3C has significant regional lymph node involvement.
Yeah, it does.
Okay. And finally, stage 4.
Yeah. Stage 4, this is where we have distant metastasis.
Right.
So it's any T, any N, but M1.
So when there's distant spread, it basically overrides the local and regional findings.
Yeah, exactly. The distance spread is the most important factor at that point.
Makes sense.
Yeah.
Okay, so as you can see, we have to be really careful when we're looking at each part of the TNM system.
Yeah. You got to
Make sure we're assigning the right stage.
Absolutely.
But, the 8th edition of the staging system also stresses that the anatomical stage is just one piece of the puzzle.
Yeah, it's not the whole story.
We need to consider other factors that impact prognosis.
Right. There's more to it than just the TNM stage.
Right.
So the latest edition actually incorporates several other prognostic factors.
Yeah.
One of the most important ones is histological grade.
Right.
So this is how aggressive the cancer cells look under the microscope.
Okay.
And then we have the receptor status.
Yeah.
ER, PR, HER2-DU, and Ki-67.
Right.
These markers tell us a lot about how the tumor behaves,
Yeah.
and they help us choose the right systemic therapies.
Right.
Yeah.
And we're using multi-gene assays more and more.
Oh, yeah, for sure. Things like Oncotype DX,
Yeah.
they really help us figure out the risk of recurrence,
Right.
especially in early-stage hormone receptor-positive disease.
Right.
And this information can help us decide whether or not to recommend adjuvant chemotherapy.
Right.
Try and personalize treatment as much as possible.
Yeah.
Yeah.
And the response to neoadjuvant chemotherapy is another important prognostic indicator now.
Oh, yeah, absolutely.
So if a patient achieves a pathological complete response,
Right.
or PCR,
Yeah.
that means there's no invasive tumor in the breast or the axillary lymph nodes when we do the surgery.
Yeah, that's a good sign.
Right, and that usually means they'll have a better long-term outcome.
Exactly. It's a very positive prognostic indicator.
Right.
And it definitely influences, how we think about residual disease and whether they need further treatment.
Okay.
Yeah.
So the 8th edition also clarified a few things that are worth mentioning again.
Oh, yeah, for sure.
Just to be really clear.
Yeah.
So, for example, lobular carcinoma in situ, or LCIS,
Right.
that's now definitively classified as a high-risk benign lesion,
Yep, that's right.
not an in situ carcinoma.
Exactly.
And this is a really important distinction.
Yeah, it is. Because it changes how we talk to patients.
Yeah.
And how we manage them.
Right.
Yeah.
Okay, and the M modifier.
Oh, the M modifier.
That's really important for documenting if there are multiple synchronous primary tumors in the breast.
Yeah. It's essential to document that accurately.
Yeah.
Because it can influence our surgical plan.
Right.
Whether we do a mastectomy versus a lumpectomy.
For sure. And then the Y prefix.
Right.
That's now the standard way to show that the cancer has been treated with neoadjuvant systemic therapy.
Yeah, so we use that Y to show the status of the cancer after neoadjuvant treatment.
Yeah.
And it helps us keep track of how well the patient responded to the treatment.
Right.
And adjust the treatment plan if we need to.
Exactly.
Yeah.
And going back to T4B.
Okay, T4B.
It's really important to remember that for a skin nodule to be classified as T4B,
yeah,
it has to be a satellite nodule.
Right. It has to be separate from the primary tumor.
Yeah.
So if the skin is involved right next to the main tumor mass,
right,
that doesn't count as T4B.
Okay. Good clarification.
Yeah, it's an important distinction.
And the definition of PCR,
right, that we
talked about earlier,
yeah,
is specifically the absence of invasive tumor
right,
in both the breast and the axillary nodes.
Yeah.
After neoadjuvant treatment.
Exactly.
So if there's some residual DCIS, that doesn't mean that the patient didn't achieve a PCR.
That's right.
Okay.
Yeah.
And another important point to remember
Yeah.
is that even if inflammatory carcinoma,
Right.
which is T for D,
Yeah.
goes into complete remission
Right.
after neoadjuvant chemotherapy,
Yeah.
it still keeps its original T4D classification.
Yeah, that's right. It doesn't change.
Right, because inflammatory carcinoma is so aggressive.
Yeah, it is.
We have to be extra vigilant.
We do.
Yeah.
Okay, and for microinvasive carcinoma,
Right.
T1IMI,
Yeah.
the definition is still the same.
Okay.
It's invasive tumor foci that are 1 millimeter or smaller.
Right.
So we really have to scrutinize the pathology reports
Yeah.
and make sure we're measuring these tiny areas of invasion accurately.
For sure.
Yeah.
Okay, and finally, the 8th edition has some very specific guidelines for how we report tumor size.
Oh, yeah, absolutely.
Yeah.
We have to be precise and consistent.
Right.
So we measure to the nearest millimeter.
Right.
And we have that important rounding rule.
Yeah.
Tumors that are bigger than 1 millimeter but smaller than 2 millimeters get rounded up to 2 millimeters.
Right.
This standardization is really important
Yeah.
because it helps us make sure that we're staging tumors the same way across different institutions.
Consistency is key.
It is.
Okay.
So as we've seen, the 8th edition of the AJCC TNM staging system for breast cancer,
Yeah.
it's a really detailed and nuanced system.
It is.
And it helps us really understand the extent of the disease.
Right.
And it's a living document.
Right.
It's constantly being updated based on the latest research and evidence.
Yeah.
Yeah.
And as surgeons, we really need to have a thorough understanding of these classifications.
Oh, absolutely.
So we can provide the best possible care to our patients.
It's the foundation of everything we do.
Right.
Yeah.
Because it impacts our surgical decisions.
Right.
And it helps us give our patients accurate prognostic information. And it's important to remember that staging isn't static.
That's right. It's a dynamic process.
It's not just about the anatomical extent of the disease.
Yeah.
We also have to consider the biological factors
Right.
and how the patient responded to neoadjuvant therapy.
Yeah. All of that information together gives us a much more complete picture.
Right. And that's how we make the best treatment decisions.
Absolutely.
And ultimately, these detailed classifications,
Yeah.
they're really important for our multidisciplinary discussions.
Yeah.
Because they help us make sure that everyone on the team is on the same page.
Right. We're all speaking the same language.
Right.
Yeah.
And that we're coming up with a treatment plan
Yeah.
that's really individualized for each patient.
Exactly. It's all about personalized medicine.
Right.
Yeah.
Okay, well, this has been a really great deep dive into the 8th edition of the TNM staging system.
Yeah. It's been a pleasure.
Thank you so much for joining me.
Thanks for having me.
Thank you for listening to our podcast.
See ya.
See you in the next episode.